Let's talk about opioid use disorder. So, couple background things about opioid use disorder. It's not necessarily a new thing, but it has had different lives throughout the last several decades, with the rise of prescription opioids and the purported safety from, as we mentioned in the classroom, uh, really a minimal article supporting its lack of abuse and misuse and dependence potential. We saw a rise in prescription opioid use and overdose. Really, kind of in the early 2010s, there was a shift towards less expensive and more accessible heroin. And part of that was to do with some of the crackdowns with prescribing opioids, but also with changing in some of the formulation. So abuse deterrent formulation of long-acting oxycodone, for example. And in the last decade or so, we've seen an influx of higher risk opioid availability. So things like fentanyl and remifentanil, et cetera, that increases the dangerousness of opioids themselves. This is also around the time where naloxone started to become more widely available to try to mitigate some of the opioid-related overdose deaths. But we saw kind of a decline to some degree, and definitely a leveling out, as you can kind of see here on the chart. But then the pandemic happened, and substance use rates, particularly with opioids, started to increase again. Starting to manage it, we've had some decreases, and hopefully we'll see continued decrease in opioid use disorder and opioid overdose. Now, specific to Ohio, there's actually dashboards that you can sort of query to find some of the data associated with things like opioid overdose deaths, so documented deaths associated with overdoses from opioids. So this chart here has up to 2022 data, as you can see, 2022. And it's been fairly stable with some more recent declines, which is good. So we're kind of back getting into a downswing of rates of opioid overdose death. But it's kind of a constant monitoring requirement, a constant need for addressing that it's not going away just yet, right? So when we're thinking about how to identify someone who might be over-medicated or overdosed on opioids, it's a CNS depressant at the end of the day. So things associated with CNS depression, right? So decrease in respiration, decrease in heart rate, drowsiness, slurring of the speech. So some of the coordination starts to become, less crisp, right? But then some more specific things that we'll see, like constriction of the pupils. Now, this depends a little bit on the type of opioid product, but most opioids will cause the pupils to constrict. And if you consume a large enough amount of opioid to overdose, the cause of death with opioid overdose is largely because your brain kind of just stops remembering to breathe. Breathing is something that, if you're not actively thinking about, is an involuntary action, right? You breathe naturally, but that is driven by your brain. And if your brain becomes so depressed, like the activity becomes so suppressed, it can forget to breathe, and then you don't oxygenate, and then you die, right? The other side, when we think about withdrawal, so someone who's been consuming opioids for a period of time and significantly decreases or stops taking opioids, there'd be a lot of unpleasant adverse effects associated with it. Things like craving, pretty common with essentially all substances that can lead to dependence and abuse and misuse. But then we see things like watering of the eyes, watering of the nose, so lacrimation and rhinorrhea. People can get flu-like symptoms, things like chills, sweating. Yawning is fairly unique to opioid withdrawal, so consistent yawning. We'll also see goosebumps or piloerection, and people can have pretty significant diarrhea. Usually, the physical danger of opioid withdrawal is the discomfort and potential for dehydration from things like the nausea, vomiting, diarrhea that people can experience, and if not provided with appropriate supportive care, can be quite dangerous. So one kind of easy way to recognize the classic signs of opioid overdose, we have our pinpoint pupils, so those tiny little black parts in the eye, right? Loss of consciousness and respiratory depression, so that lack of breathing. Now, there are a lot of products that are now available to address opioid overdoses. So we have reversal products. The first that came around was injectable naloxone, but now we have a lot of different formulations of naloxone, not just a prescription vial that is used a lot of times in hospital and emergency settings. Now we have intranasal, so the Narcan intranasal. We also have the Rextovy spray. We have the intramuscular injection, so Zimi, for example. And then we also have now available for prescription the nasal spray formulation of nalmefene, which is an opioid overdose product as well. So looking at the different products here instead of just the visual, we have our Narcan, Cloxato, Revive, Rextovy, and then some generics, right? And over-the-counter, Narcan and Revive. So you can actually purchase over the counter now intranasal naloxone as a reversal agent. So there are different dosing here, so we can go from a lower dose to a higher dose, but just be kind of aware of the brand name products and which are OTC versus prescription. The rest of the types of products are all prescription only. So we have the injectable naloxone, including Zimi, and then the intranasal nalmefene, including Opvee. And then there is an auto-injector that has been approved, but I haven't been able to see that it's available actually yet. It was purported to be available sometime this year. As of September of 2025, still not available for prescription just yet. Then when we're looking at screening for opioid use, so if someone might have high-risk opioid use or concerning for, individuals who might be a good candidate for opioid management. So there is kind of your generic type of intervention. So our ASPIRTs, so the screening, brief intervention, or referral to treatment, that's our general screening for substance use, but absolutely applies to opioid. And then we have the SOAP-RR, which is a screener and opioid assessment for pain. So this is something that can be applied to individuals who may need opioid pain management to determine their overall risk. We also have the screening for risk of opioid abuse or misuse tool, so the opioid risk tool that can be utilized. There's a couple others, but these are some of the primary ones that can be applied in different situations to kind of stratify or screen for some of the risks associated with opioid use. Now, in the case of withdrawal, the most common withdrawal scale, kind of similar to with alcohol, we talked about the clinical assessment for withdrawal scale, so the CWA. We have the COWS. That's the most common one that you're going to see. So the clinical opioid withdrawal scale. And this is a clinician-rated tool, can be used outpatient, can be used inpatient, and it helps to kind of follow symptomatology within the withdrawal course itself and is stratified by the score, right? So it can be mild all the way up to severe. We also have a similar one, but that's self-rated. So the SOWS, or the Subjective Opioid Withdrawal Scale. And this helps to do the same kind of thing, right? But it's asking the individual who might be experiencing withdrawal to fill out. We also have a specific scale for what we call iatrogenic withdrawal in specifically the pediatric population. So this is for individuals who are children that may be exposed to CNS depressants like opioids and benzodiazepines for medical purposes, and screening for the presence of withdrawal. So the WAT-1, or the Withdrawal Assessment Tool 1. And to go into the neonatal aspect, because that is a concern that can happen where someone gives birth to a baby that has been exposed long term to opioids, the Finnegan Neonatal Abstinence Scoring System, that was a tough word apparently, system for NAS, we can use, right? So this is a clinician evaluation of opiate exposed infants shortly after birth. So what does the cows look like? These are the scoring parts in the cows. So we have things like your pulse rate, if they're sweating, if they're restless, the size of their pupils, achiness, that rhinorrhea or lacrimation, nausea, vomiting, diarrhea, tremor, yawning, irritability, and the piloerection. So that helps to assess for how severe and how many symptoms someone might be experiencing with withdrawal. We can offer some supportive medications and interventions, as well as can use this to help if someone is undergoing what we call an induction, right? If they're being transitioned to a medication for opioid use disorder. Now, the timeline for opioid withdrawal can vary pretty significantly, of course, based on our typical things like how long they've been using an opioids for, the dose, the type of opioid. So different opioids have different pharmacokinetic parameters. Things with longer half-lives, you might see this start off later or last longer. Fentanyl is kind of interesting because even though it is purported to have a really short duration of action, with repeated use, it can sort of build up into the adipose tissue and actually have more of a prolonged, protracted withdrawal. And you can actually precipitate withdrawal sometimes if you administer buprenorphine as a induction medication for someone using fentanyl because of that kind of continued leak, if you will, right? So usually what you see is in the first few days, the peak symptoms will occur. So that's the sweating, diarrhea, nausea, vomiting, aching muscles, restlessness. Pupils get really big. But as the kind of peak physical symptoms of withdrawal subside, individuals can still experience a lot of mental health related concerns and, prolonged disturbances in things like sleep, irritability, depressive symptoms, and cravings, right? Cravings can occur fairly quickly, but last for weeks to months. So it can be a long-term syndrome that people can experience following opioid withdrawal. Now, when we're evaluating someone for opioid use disorder, in addition to some of those scales that we talked about, things like the SBIRT, et cetera, there's also some laboratory testing and other screenings that can be helpful in evaluating for use of products, what kind of treatment process should happen, if they're ready for treatment, et cetera. So assessing for co-occurring medical conditions such as sexually transmitted infections, hepatitis, and HIV, if they've had a history of trauma or current traumatic injuries, as well as pregnancy status, co-occurring psychiatric illnesses. If you recall, individuals who have poorly treated or untreated mental health conditions may use products like alcohol, stimulants, opioids to help manage or cope with their symptomatology. So treating some of that underlying cause can be really helpful, but it can also be challenging to address their symptoms of their mental illness until we manage their opioid use disorder. Okay. And of course, there are a good number of individuals who may have more than one substance that they frequently use. So we may be trying to manage multiple substance use disorders that are co-occurring. So things like cannabis use disorder plus opioid use disorder, right? Alcohol use disorder plus opioid use disorder. Sometimes we'll see stimulants and opioids. So lots of different things kind of working together to create the clinical picture of what we're going to prioritize and address. Other things that are really important, so performing urine drug screens, baseline, and then based on, the treatment and their follow-up, random and periodic urine drug screens can be really helpful for monitoring their use, their compliance with a medication for opioid use disorder, and potential for use of other substances. Particularly if they're on naltrexone, which is a medication we'll sometimes use for opioid use disorder, liver function tests, absolutely. And then things like our depression screenings, etc., and vitals. Electrocardiogram, particularly if someone is going to be prescribed or currently taking methadone because of its risk for prolonging QT interval and potential for inducing cardiac arrhythmias. And there are risks for things like drug-drug interactions, whether they're cytochrome P450, pharmacokinetic, or pharmacodynamic interactions. We should be aware and monitoring appropriately for all of those.